in many ways, gastrointestinal stromal tumours have led the way in terms of biomarkers of response to therapy in sarcomas. We know, for example, that patients with tumours harbouring the PDGFR alpha D842V mutation do not respond to Imatinib. So those tumours are generally resistant to Imatinib, but are very sensitive to another drug called Avapritinib. There are other data from the two initial randomized trials of Imatinib indicating that 800 milligrams of Imatinib is more effective in patients with tumours harbouring the KIT exon 9 mutations. So in many ways, we've got a very good evidence base for markers of response to therapy in gastrointestinal stromal tumours. And of course, there is an ongoing trial for patients with disease progression on Imatinib, randomizing patients based on ctDNA to either receive ripretinib or sunitinib. And this trial is open to patients with disease progression on Imatinib with ctDNA evidence of KIT exon 11 plus KIT exon 17, 18 mutations. So there is ongoing work in terms of markers of response in gastrointestinal stromal tumour. In terms of the second part of your question, I think that, again, ties in with the heterogeneity of sarcomas, particularly the heterogeneity of complex karyotype sarcomas, such as angiosarcoma, osteosarcoma, and leiomyosarcoma. Some of these tumours can be both morphologically heterogeneous, but also molecularly heterogeneous. And I think it's very challenging to develop an all-encompassing biomarker from biopsy material for such a tumour. And I suppose what we need to work on is a combination of potentially functional imaging markers as well as tumour tissue markers. But I'd say for sarcomas, that's an ongoing field of research. And because of the complexity and heterogeneity of these tumours, we still face considerable challenges.